So good afternoon, everyone. My name is Sandra Arevalo. I'm the Director of Community Health and Wellness at Montefiore Nyack Hospital, and this is Community Chats. So today we're going to be talking about cholesterol, everything about cholesterol. We'll see how far we get because this can be an extensive topic, and I know that it can really impact a lot of us. So today we're going to be having two doctors with us and a registered dietitian who are going to tell us, how to manage cholesterol, what is cholesterol, all of these things that we want to know. Now, just a reminder to our attendees that this is supposed to be an interactive show. So please use the Q&A box or the chat box and ask your questions, and I'll be reading your questions to our panelists. Also, this session is going to be recorded and it's going to live in the Community Chats YouTube channel and also in our Montefiore Nyack webpage. That way you can share this information with any loved ones, neighbors, friends, anyone who you think might benefit from the information. I'm also going to be sending the link to all of those who have registered and not being able to attend. But without further ado, let me start with introductions. So ladies first, Elizabeth, do you want to tell us a little bit about yourself?
Sure. I'm a registered dietitian. I work at Montefiore Nyack Hospital in a variety of areas. And I personally have familial hypercholesterolemia or high cholesterol. So I have implemented a lot of these suggestions for myself to try to keep my own cholesterol down.
Okay, thank you for sharing that. Dr. Brian?
My name is Dr. Dwayne Bryan. I'm a non-invasive cardiologist at Montefiore Nyack in private practice in West Nyack, but affiliated with Montefiore Nyack. And I'm happy to be here.
Thank you. Dr. Rios?
Hi, Sandra. Good afternoon. How are you doing? My name is Saul Rios. I'm a cardiology fellow here at Montefiore Medical Center. I did my residency in Jacobi Medical Center, also in the Bronx. So I've been serving this community for the past 7 years, and I'm happy to be here and continue contributing on educating the community on cardiovascular topics and cardiovascular health.
Thank you so much. So, let's start with what I think should be an easy question. What is cholesterol? Dr. Brian?
So first of all, I'd encourage people to ask questions because it's a very broad topic and sometimes it's easier to respond in that way than a didactic session on cholesterol, but that's a good starting question. So cholesterol, it's one of the blood fats or lipids that circulate in your system, and I think it's important to know because the name cholesterol sort of has a bad implication, but cholesterol is very important for bodily functions, for maintaining integrity of our cell membranes. Many hormones in our body are cholesterol is used to make them, as well as other components of our system. So cholesterol is actually very important. It becomes a negative when cholesterol levels are elevated because it can have negative effects on our arterial system in particular, but cholesterol is very important for our day-to-day function. It's just a matter of maintaining it at appropriate levels, and when abnormal, managing it to prevent it from causing these issues that we'll talk about going forward. One thing I wanted to bring up, people always think of cholesterol in terms of its effect on the vascular system as having a negative effect by causing quote unquote clogging of the arteries. And it's a lot more complicated than that description. It's actually not clogging of arteries. It's that cholesterol gets into our arterial wall and it helps, along with other factors, to promote plaque formation in your vessels. And that's where cholesterol has a negative impact in that way.
Dr. Rios, would you like to add something?
Oh, thank you. No, that was a very detailed description. Cholesterol is basically one of the most important building blocks for repairing tissue, cell membranes, and creating hormones in our body. So even as Dr. Brian was saying, it may have a negative implication, but it's a necessary building block for many metabolic processes in our body. It's so important that we actually get up to 75% of our cholesterol from the production that our own cells have. And then we get that, the rest complemented by what we ingest in diet. So this molecule has many functions, and most of it circulates throughout our blood, and it can get stored as well in sites like the liver. And in the liver is where the cholesterol also gets discarded whenever we have excess cholesterol.
Yeah, a way that I used to try to explain this to patients was as if you're looking at a highway, right? And the highway is kind of your circulatory system, and then you have a jam there, like an accident or something, and of course there is an obstruction, and then you get a lot of traffic, and that accident, that obstruction, it's kind of what the cholesterol will look like. And I was just remembering this because Dr. Brian, you mentioned plaques, right? So would this kind of metaphor describe those plaques that you were talking about?
Yes, definitely in a way. I think when we use the term cholesterol, to be more specific, we refer to, and I'm sure everyone's aware of the terms LDL cholesterol and HDL cholesterol, because cholesterol doesn't actually circulate in your system freely. It's actually carried by these particles called, well, HDL is high density lipoprotein and LDL is low density lipoprotein. And so it's sort of packaged in these particles because by itself, the nature of cholesterol is that it wouldn't really, it's what we call hydrophobic. So it doesn't actually function well to be transported within our blood system. So it's carried in these proteins called lipoproteins, and that's where HDL and LDL come in. To answer your question, it's these particles that actually get promoted and get into the cell wall that initiates the process of plaque formation. And and that's why those are the numbers that we're more familiar with. When we say cholesterol, we're all familiar with the terms of LDL and HDL cholesterol, but I think your highway description sort of does make sense because it transits within your vessels, and it's I guess you could think of it as exiting into your blood vessel walls. And it's a process of them being incorporated there that initiates the process of plaque formation.
Now, I don't know if a lot of people are familiar with LDL, HDL, although, again, when we get a test result, we see total cholesterol. And as a matter of fact, I took the time to bring up an image of that. So let me just quickly, if I can. Am I sharing something right now? No.
Briefly.
Briefly. Okay. So it's in here. That's not it, right? Are you seeing like a table or not?
Yes. Yes.
Okay. So this, right? It says lipid profile, and then this is exactly what you were talking about. It says HDL, LDL. Are you looking at a picture right now?
Yes, we
Okay,
can see it.
perfect. So, we usually say, oh, we did a cholesterol test, but then we see all these other names in there, and you were just explaining high density lipoprotein, low density lipoprotein. Does this have something to do with what we say it's like the bad cholesterol, the good cholesterol?
Yes. So, and I'll let Dr. Rios chime in after, but so there's certain particles that are what we consider atherogenic, or the ones that are more prone to causing the process that I mentioned of plaque formation. And so the LDL cholesterol and triglycerides are two of the particles that are more prone to promote that process. And so you could kind of think of those as the bad cholesterol particles. HDL, or the high density lipoprotein, actually may have the opposite function, where it may actually reduce. It actually participates in something called reverse cholesterol transport. So it actually may help to clear cholesterol out of your system. So obviously that's more of a positive than a negative, but the atherogenic particles, the LDL in particular, and triglycerides are the particles that can more promote plaque within your arteries. And so this panel that you see here just sort of gives you a representation of where a particular patient would stand. And obviously you'd want to promote lowering of triglycerides and LDL cholesterol because those are the quote unquote bad particles, whereas the HDL you may want to optimize, even though the benefits of raising HDL isn't really clear. But that's sort of how we generally think of a basic cholesterol panel like this. Is just kind of gives you a sense of where you stand in terms of these particular particles and the impact they may have on your risk of cardiovascular issues.
So back to my highway example, I will think that the triglycerides and the LDLs are like the cars that cause the accident, right? While the HDL is like the tow truck trying to clean everything up.
That's a great analogy.
Okay, just trying to put it in terms that people can understand. Dr. Rios.
Yes, Sandra, thank you for bringing up this table. I think it's crucial for our patients to understand their test results, and that way they can be an active participant in their healthcare. And thank you, Dr. Brian, for the excellent explanation. So what we're seeing here, it's the levels of different components. Cholesterol refers to the total level of particles. And then you have different types of cholesterol, and basically we classify them by their density. So high density lipoprotein or cholesterol, or HDLC, it's a larger type of particle, and because it's larger, it's less dense, so it's considered to be a high density particle. And like Dr. Brian says, it's typically considered the good cholesterol because it helps remove cholesterol from our body. It takes it from the circulation, from the highway, and it takes it into the liver where it can get disposed of. On the other hand, low density lipoprotein, these particles are denser. They have less density, meaning that they are smaller particles, and that conveys them the risk of getting into the arterial wall and causing plaque. It's important to understand that cholesterol doesn't cause the initial insult that leads to the obstruction formation. That may be caused by other things like inflammation, high blood pressure, high blood sugar, and then cholesterol acts like a bandage to try and repair the damage. However, when it starts accumulating, it can lead to an obstruction and a restriction of blood flow to critical organs like the heart, causing a heart attack, or like the brain, causing a stroke. So basically, we have to be familiar with what our numbers are and what the normal numbers for someone with our age and our risk factors are, because not everyone will have the same requirements for cholesterol. For example, younger patients, female patients that are planning on getting pregnant may not want to have the same cholesterol level as an elderly person who already had a heart attack. So that's something that we need to keep in mind as well.
Mm-hmm. And thank you, Dr. Rios, for bringing that up, because, you know, I have another table here. And it has so many numbers in it, right? And I think that it's somewhat related to exactly what you were saying. So what is considerable normal or acceptable? And I don't know if these numbers are correct. I just pulled them up, but.
So in general, I think you have to individualize your therapy. If you have other risk factors, like your age, your gender, your high blood pressure, your diabetes, we basically input all of those risk factors into a risk calculator. So when the risk calculator tells us that you have a high risk, which is typically considered about 7.5% of having a cardiac event in the next 10 years, then we consider that we need to treat your high cholesterol. Typically, we start with diet and exercise, and then if that doesn't work, we aim to give you medication. So, for example, let's take the LDL cholesterol. So the LDL cholesterol, we want it to be below 130 in the general population. But if someone had a heart attack, if someone has more cardiovascular risk factors, we're going to be more strict, and we're going to aim for a cholesterol as low as less than 70 milligrams per deciliter. Again, the decision to start treatment depends on your age, your risk factors, and if you have had a cardiovascular event in the past. So very important to learn, whenever you have an LDL cholesterol that's above 190, that's a big red flag. We start treatment regardless of your risk factors. If it's below 190, but it's still high, then we take your considerations, your risk factors and other comorbidities, and then we make a joint decision with the patient whether it's the right time to start medication or if we want to do other lifestyle changes first.
Mhm. And Dr. Rios, you're mentioning risk factors. We haven't touched on that, so maybe the three of you can mention a few of them.
I think for sure, high blood pressure, high blood sugar, and family history, I think, are the ones that come to mind the most, and overweight and obesity.
Mhm.
One of the other things that we, in addition to the risk factors that Dr. Rios mentioned, to kind of add to this mix of individualized decision-making is, you may have all heard of a test called a coronary calcium score, which we often do now. And the whole point of it basically is that, yes, we look at risk factors to identify based on a risk calculator what an individual patient's risk might be, but a calcium score is a test we do to ascertain whether someone has the beginning of plaque formation in their arteries. And that's important because you may look at, a particular target a little bit differently. So if someone already has evidence of what appears to be early plaque in their arteries, then you may be more aggressive up front and may be more likely to initiate therapy at that time rather than either waiting or deciding that particular patient, may not need therapy. So a calcium score is also part of the mix that sometimes may push a physician or cardiologist to start someone on therapy, in addition to looking at their risk factor profile to decide if they're at risk or not.
And when should we start checking our cholesterol? At what age?
Typically, I think it's never too early. I think generally in a pediatric age group, it's a good idea to have, and I think the recommendation actually is to start at that time. And then in adulthood, it's recommended in your probably mid-20s or so, you should, if you've never had it done, have a baseline cholesterol level done. And at minimum every 5 years subsequent to that. Standardly in practice, we often do it, someone comes in for a general physical, it's often done as part of the routine profile. But I think the point being that having that information is useful, and it's never too early, number one. And, from a cost effectiveness standpoint, if someone has normal cholesterol levels, there's probably no utility in doing it every year. But I think the point being is that it should be screened periodically so that if someone has elevated cholesterol, if they have a change in their numbers, you can be on top of it to start this management at an early point, because the earlier you start addressing it, the more impact and risk reduction it's going to have over time.
Now, are we referring to just the blood test, or what about this cardiac calcium score? Should everyone have it, or and at what age should you start? And actually, this is a question from one of our attendees.
Yeah. So the calcium score, and I'm sorry, Dr. Rios, I know you're going to speak, but the calcium score, you have to keep in mind that it's a test that involves radiation. So obviously it's not a test that you want to do on a regular basis, number one, and you also don't want to do it unless it's going to change your decision making. So before you order a calcium score test, you kind of have to decide how the information is going to affect what you decide to do. If it's a patient that you're already going to put on statin therapy and treat aggressively, then the information is not really going to change your management, so it wouldn't be useful. But in someone over the age of, let's say 40, between 40 and 75, where they're kind of in an intermediate range and the information may push you to say this person warrants therapy versus not if the calcium score is low, those are the kind of patients where where it's going to have an impact on treatment where you would consider doing it, but just not routinely.
Dr. Rios?
Thank you, Dr. Brian. Yeah, I think at least in my clinical practice, we do calcium score on those patients that have some risk factors, but their cholesterol is not high enough, or some patients that have a significant family history of early coronary artery disease, and they want to know, is it the time now to start medication? They don't have the typical high risk factors, so if the calcium score is going to change our management, that's when we recommend it, because these intermediate patients, if their calcium score is negative, then we tell them, okay, your risk is likely not that high, so we will hold off starting medications right now. But if their calcium score comes out high, then we can say, okay, now this is actually changing our management. We're going to start medications right now. It's a newer therapy, but it's also complementing the test that we've had for many years, like the cholesterol test.
Another question from one of our attendees: for a child age 3 whose parent has familial hypercholesterolemia, would a pediatrician automatically include this in the blood work? Is testing?
That's a great question. I'm actually not familiar with testing in the pediatric population. We typically take care of patients aged 18 and higher, but I think maybe Elizabeth has some experience to speak from, and she can tell us.
Just because I have familial hypercholesterolemia, and I would say that you can't be sure of what each pediatrician is going to do. So if you have a child like that, I would suggest you do what I did, which was to bring it to the pediatrician's attention. And then the first time that my children were going to get blood work, because no one wants to give blood work to a 6-month-old or a 1-year-old because they scream a lot. So the first time that they had to have it anyway, I advocated with the pediatrician, and he did a lipid panel, and that's how he was able to see that it didn't appear that my familial hypercholesterolemia was passed on to either of my kids, because their lipid panel was normal, whereas when mine was done as a child, it was elevated, and we could see that my father had passed it on to me.
That's very interesting. However, is it okay to assume that with age, your cholesterol levels are also going to go higher? So even if you have a small child who doesn't present with high cholesterol at an early age, I guess there has to be some sort of surveillance to see if the cholesterol levels are, going higher with time.
So I think my understanding, and hopefully one of the cardiologists can supplement it, but the reason that my cholesterol was elevated at an early age is because there's a really excessive production of cholesterol by my liver due to a genetic, difference or defect. And so even when I restrict my saturated fat intake a lot, my cholesterol is still elevated. It makes a difference, but my cholesterol is still significantly elevated above, a normal person eating an average American diet. So that's why, even though my children were small, you would still expect, if they had this genetic defect, that their cholesterol would already be elevated. That doesn't mean that it can't go up, later on. Of course it could, but because they didn't present with a high, just like I believe if you have 2 genes for familial hypercholesterolemia, then you tend to see extremely elevated values and maybe fatty deposits under the skin and things like that. But maybe one of you can, supplement this information.
Yeah, just like by quickly looking it up online, because we don't screen these type of patients, but it seems like they typically recommend to screen for the first time at 2 years old. If you have a history of familial hypercholesterolemia, then you screen again between ages 7 and 9. And then you screen for a third time between ages 17 and 20. And afterwards, 5 years intervals, you keep doing it until you hit age 40. And then you do your standard screening, which is based on your cardiovascular risk profile.
Excellent.
I'm sorry, to supplement what Elizabeth was mentioning before, one of the more common types of familial hyperlipidemia, there is a genetic defect where the body doesn't have these things called functioning LDL receptors, and the LDL receptors actually help to clear cholesterol from the system and have it taken up by the liver. And as she mentioned, if you have two defective genes, you really have very little functional LDL receptors, and as such, your serum cholesterol levels are very elevated, meaning in the several hundred range. I mean, numbers that people typically aren't used to hearing of or seeing. And if you only have one gene as opposed to both being functional, your levels may be not as high, but certainly much higher than the general population. And even if you eat a perfectly normal diet, you're still going to have significantly elevated levels that warrant medical therapy. And it's actually not as uncommon as people think. It's fairly common, especially people that have one gene as opposed to both genes being defective. And we generally think when we see people with LDL cholesterol levels over 190, 200 milligrams per deciliter, that's often a clue off the bat that they may have some, genetic or familial hypercholesterolemia issue.
I think this is a great segue to my next question, which is treatment. So you're talking about some diet, some medication. So let's go deeper into that. I think what's the first thing you try with somebody who has high cholesterol? Is it dietary changes?
Mm-hmm. Yes, and maybe I should defer to Elizabeth to speak to this, but certainly, dietary recommendations would be number one to start with.
Right. So, trying to look at the typical diet that person is eating and seeing what changes they can make that might potentially lower their cholesterol. And we don't want to forget that increasing physical activity is another effective means of lowering the LDL cholesterol, triglycerides. But with the LDL cholesterol, going back to what we were saying about what does cholesterol mean, I think it's confusing for some people because we talk about cholesterol and we want to lower our cholesterol. And so many people, they think, oh, I look at the label, I see this has no cholesterol, so this probably, it must be fine for me. And it's not the case, because when we refer to dietary cholesterol, we're referring to that waxy lipid that Dr. Bryan stated is incorporated within the LDL, right? So, that cholesterol in our diet, which only comes from animal-based foods, that's that's a small part of how the diet might affect your cholesterol. We get a little bit of our cholesterol from the diet, but most of our cholesterol we get from when our liver creates it. And one of the things that most causes our liver to create more cholesterol that then gets incorporated into the low density lipoprotein is dietary saturated fat. So that's actually the much bigger dietary concern. When you look on the food label and you see, total fat, and then what's actually most relevant is the saturated fat. So this type of fat is the one that tends to raise the LDL or, bad cholesterol more. And you tend to see it in, fattier red meats and pork and chicken skin or turkey skin and fried foods, a lot in dairy products, creams. And so there are a number of foods that if you can really cut down on your consumption of these, it can really help a lot to lower your cholesterol. So generally we recommend that people get maybe, less than 20 grams of saturated fat a day. If it's somebody who's having trouble lowering their cholesterol, or they have familial hypercholesterolemia, we would tend to recommend an even stricter goal of, around 12 grams of saturated fat a day. So that's one of the, the biggest factor. There are other things, for example, the more dietary fiber you have, that tends to help lower the cholesterol. And obviously, the more we eat healthful foods, like foods that are sources of healthier fats, like salmon or nuts or olive oil or avocado, that can help to, keep your cholesterol down. It can help to keep the hello? Okay. Oh, thank you. Sorry, it all disappeared. It can help to lower your triglycerides, for example. But the foods that are higher in fiber, there's one type of fiber, which is called soluble, in other words, water-soluble fiber, and that can also help to lower cholesterol to some extent. The reason being that soluble fiber tends to link up with something called bile acids. So bile acids are secreted, created by our liver, secreted into the intestine, and they help us to absorb fats from our diet. When you have more soluble fiber in your diet, it kind of connects with some of the bile acids, carries them out of the body. Bile acids are made in part with cholesterol. So for example, I would think of it as my liver, through it, because of its defect, is creating too much cholesterol. When I eat a high soluble fiber diet, it kind of brings those bile acids out of my body instead of being reabsorbed completely. And so it creates a purpose for some of that excess cholesterol that my liver's producing. So it helps to lower my cholesterol levels slightly. So this soluble fiber can be found especially, in lots of, whole grains, fruits, vegetables, but especially in foods like oats, barley, all kinds of beans, black beans and chickpeas and lentils. I use psyllium husk fiber, which is in Metamucil, for example. It is not a delicious thing, but it is something that has a lot of soluble fiber. So if you use it between 1 and 3 times a day, it will again help to link up and pull those bile acids out of your body and slightly reduce your cholesterol. So that high soluble fiber intake can help a lot to lower cholesterol as well. And there's also something called Stannols and Sterols. They're not really naturally present in a lot of foods, but they have some supplemented foods. Mostly though, you find them in these special like spreads that you use, like instead of butter, Take Control, Benecol. And so I don't recommend like starting to use it in your diet, because it also comes with a whole bunch of other fats. I don't recommend adding it to your diet in addition to whatever you were already eating. But let's say you like butter or you're using another spread. These spreads would have less saturated fat than butter, and they also have Stannols and Sterols, which which can help to kind of lower your cholesterol as well. So those are a few ways in which changing your eating pattern and the nutrients that you're getting can help to lower your cholesterol.
And Elizabeth, there is a nutrition facts label here. I hope you all can see it. And when you're looking at total fat, it says the saturated fat and the trans fat, which we haven't mentioned the trans fat. So what's the role of trans fats in all of these? And what are trans fats?
So trans fats are another kind of fat, which is, if anything, more damaging, raises your cholesterol even more than the saturated fat. In recent years, we've been seeing it less and less often in foods because it's they saw how damaging it is. And it's not, for example, in butter, that saturated fat is naturally existing. Trans fat doesn't exist in significant quantities and naturally occurring in food substances, but when they hydrogenate oils to increase their shelf life, for example, for all those foods, the crackers might have it, or shortening might have it. So all these kind of processed foods, they used to use it in large amounts to kind of make it shelf stable, but have less saturated fat. But as they discovered that the trans fat is even more damaging, that's why the food companies have started to change it. So if they're going to use that kind of shelf stable fat, more often they're just using saturated fat anyway. But if you see foods, like certain foods still are high in trans fat, that would be a food to definitely stay away from.
Okay, so trans fats, no good. We're gonna try to avoid trans fats. And we have lots of questions here now from our participants. For an individual with familial hypercholesterolemia who has made attempts to drive down their cholesterol in the absence of medication, what will this team suggest that will help achieve this person's goals?
Well, first, I think all the things we were just talking about are beneficial. And I would say for example, you can look at all the different foods you're eating and whether there are alternatives that are still acceptable that would be lower in saturated fat. For example, people are always asking, is it okay to eat eggs or not? And I would say somebody who, their cholesterol is fine and they're eating 1 egg a day, then that's fine. If you have familial hypercholesterolemia and you're not achieving your goal, maybe you decide to only have 3 eggs a week, or maybe you decide to only have egg whites. So you can take a look, or maybe you're having 2% milk. Maybe you should change to 1% milk. So you can find alternatives that are lower in saturated fat, right? Along with seeing if there's a way to increase your physical activity. We didn't mention as well, obviously want to stop smoking if you're smoking, right? That's another factor that's important. So I think all the different dietary changes, you want to try it and you want to see within the confines of my life and what I'm able to achieve, am I doing the most that I can? Am I sustaining this change for 2-3 months and then retesting my lipid panel to see whether or not I'm able to achieve the goal?
And Elizabeth, what about wheat germ?
What about wheat germ?
Yeah.
So, is
The
that one of
question is, what about wheat germ for fiber? That's the whole question.
So wheat germ has fiber, it has vitamin E. So I think it's fine to include. It has some, has some fats in there. I think one other that's especially beneficial is ground flaxseed. When we're thinking of these like little fibery things that we're going to add to our yogurt or our cereal or whatever, I especially recommend for lipids, the flaxseed, because it has both healthy like omega-3 fats, like precursors to omega-3s, and then it has a lot of soluble fiber as well. Yeah.
The other thing I would add to Elizabeth's comment regarding the prior question was, regarding the familial hypercholesterolemia is that, and I counsel patients on this, that even if you have a poor diet and you make optimal changes in your diet, it's probable that at best you might reduce your LDL cholesterol levels by maybe 25 to 30%. And depending on where you're starting, especially someone with very elevated lipids, that's quite likely not going to be enough. But in addition to that, what comes with having some of these genetic hyperlipidemia issues is also a higher risk and a family history of having coronary disease and coronary disease issues. And so the treatment is not solely based on just reducing cholesterol numbers. You're also trying to reduce cardiac risk and cardiac events. So these patients, just solely based on the numbers, but also their family history and cardiac risk, often do need medical therapy to reduce that risk. So I guess the point being that it's not just about reducing numbers, it's about reducing risk. So it may be, very hard or unavoidable that, someone may not, the dietary changes are critically important, but medical therapy is usually going to be indicated on top of that as well.
Mm-hmm. Yeah, so sounds that for that question, the answer is if you tried everything, like every lifestyle change, dietary change, and all of that, and your numbers still are high, you probably need medications, correct?
Correct.
Right, but to your point, I'm curious. So for example, I'm 44 years old and I have a strong family history of, in that line that I inherited, people dying, let's say in their early 70s of, heart attack. So given that you just said it's not just about the number, if you had a patient who, let's say, was able to keep their LDL only mildly elevated with familial hypercholesterolemia, at what point does the risk formula say, even so, given that you have this family history, this is when we would start treating with a statin or something like that?
Yeah, so basically, across all even baseline LDL cholesterol levels, there's a lot of data that show that statin therapy in particular reduces cardiovascular events by, anywhere from 20 to 30%. And so, even with levels that are seemingly controlled or what you might consider acceptable, again, with that family history of heart disease, you're going to be someone that I think most people would put on medical therapy to achieve that goal. Because statins also, yes, they do reduce cholesterol, and that's the main effect of it, but it also has other properties, anti-inflammatory benefits that, you know, reduce inflammation and plaque formation and stabilize plaque to lower, you know, cardiac events. So that's really the impetus for statin therapy. Yes, it does lower cholesterol, but there's extensive data that shows that it reduces, you know, the ultimate, you know, issue is preventing heart attacks and stroke, and there's data to support it. So I do get the idea that the dietary approach is critical, and everyone should adopt a strict dietary reduction of cholesterol strategy. But remember, the goal is to prevent events, and that's where I think medical therapy on top of that often is indicated.
Yeah. And I think that we are touching a little bit on the answer to this question, but Virginia is asking, at what numbers do doctors typically recommend medication for cholesterol?
Well, I think speaking from experience, we rarely target a specific number except when the cholesterol is very elevated. And it's also important to keep in mind which cholesterol we're talking about. So we take more importance into the low density lipoprotein or LDL cholesterol. And whenever someone has an LDL over 190 milligrams per deciliter, that's when we decide to intervene. But there's basically a classification and 4 groups that actually require treatment for the cholesterol. Anyone that has diabetes should typically be started on medications for their cholesterol because diabetes is considered a very important cardiovascular risk factor. Anyone that has a cardiovascular risk factor of over 7.5% in the next 10 years, typically we start calculating these risk factors at age 40. They should be treated for cholesterol regardless of their number. And anyone that has had a cardiovascular event, that's including a stroke, a heart attack, anyone that has a stent, anyone that has vascular disease on their lower extremities, they also should be on a statin regardless of their cholesterol level. And we typically aim for lower numbers of cholesterol in this patient population because they will be at the highest risk of getting a recurrent event. So we don't always go by the number except when it's very elevated. And like I said before, an LDL above 190.
190. Okay. Dr. Ryan, would you like to add something?
No, I think that was actually, you know, very well detailed. But I think the main point being that it's rather than, you know, as Dr. Rios said, certainly if it's over 190, that in and of itself warrants therapy. But we sort of move towards assessing individual risk. So that's why it's kind of hard to answer that question. So we sort of assess a person's individual risk, and if they're in a risk category where we think they're high risk for having a cardiovascular event, then that's really the impetus to start therapy. So someone could have an LDL cholesterol of 120, and you could have a similar individual with a LDL cholesterol of 150, but you may treat the one with the LDL of 120 because when you look at the global picture, their risk is actually higher than the person who has the LDL of 150. So that's why it's as Dr. Rios said, there's not necessarily a number cutoff. It's really a risk assessment of that individual. And again, that's also to the point why you see your doctor to kind of do that risk assessment to decide if you're a candidate to be on to require therapy.
And I think that if doctors are telling you that you need medication, then you need medication, right? Because you're doing the assessment on a personal level. There might be other people who have higher cholesterol, they don't need the medication, but if the doctor is telling you you need the medication, I will say, go for it.
Correct.
And Carrie's asking, is our cholesterol only affected by fats? I heard dietary sugar also has an effect.
So I think also it might be a good idea to talk about the LDL versus the triglycerides, which we mentioned are 2 lipids that are both damaging. So the LDL cholesterol, although it's never good to be having, you know, a lot of added sugars in your diet. It's not good in general. However, it's not a primary factor that tends to raise your LDL or bad cholesterol. Versus the triglycerides, which are more free floating fats in the blood, that can be greatly affected by your sugar intake as well as refined starches, like things that are made with white flour or a lot of potatoes. So if your triglycerides are elevated, then I would say it's equally important to look at your you sort of like refined carbohydrate, starch, and sugar intake, as well as your saturated fat, because those two factors both affect your triglyceride level a lot.
Yes, thank you for that. Anything to add, Dr. Brian, Dr. Rios?
I think Elizabeth stated it perfectly. And as a cardiologist, I will say that we appreciate the advice of, of trained nutritionists and dietitians, because we often make recommendations to patients that are somewhat generic about, reducing your cholesterol and eating healthier. But to actually get specifics in terms of telling patients, what they should and shouldn't eat and how these things sort of come into play, it's actually very helpful to have, an expert give their perspective as well.
Thank you for that. And then exercise. We haven't talked about exercise, and we have a question about exercise. So I will rephrase the question to ask, what is the role of exercise in all of this? Because, all the time that we go to the doctor, they are like, exercise, but why do we need to exercise for cholesterol?
I think along with diet, exercise is one of the staples for keeping an overall healthy lifestyle. Exercise will increase the amount of fat tissue that you utilize. So instead of your body storing the excess calories as fat and as particularly in your liver and your peripheral fat, this causes a state of inflammation. So it will decrease your cholesterol levels, not so much to the same extent as diet or medications, but overall it will enhance changes in your body that will decrease your cardiovascular risk. So of course, exercise is very.
Anything else? How much exercise do you think is recommended in order to help with the cholesterol?
I don't necessarily make the recommendation solely for cholesterol. In general, just from a cardiovascular health standpoint, we try to, obviously the more the better, but I try to encourage people to do 5 days a week, 30 to 45 minutes, a clip of aerobic exercise, and certainly has effects on your weight, which in turn will help to reduce your cholesterol levels, as well as your overall cardiovascular risk. So yeah, the more the better, but at minimum, I try to encourage people to do that. But also I tell people that anything more than what you're doing now is beneficial as well. So if you do nothing now and you could manage 5 to 10 minutes of exercise a day, it's better than nothing, but the goal should be to move towards, 5 days a week, 30 to 45 minutes a clip.
Mm-hmm. Well, thank you. And we're running out of time, but I think that this is a very touching comment that we are receiving here. Is someone who has lost her son to an enlarged heart because the disease runs in the family as well. So she wants to know, how can I inform or encourage other members of my family to seek both medical and nutritional help?
Yeah, I mean, that's, really, oftentimes when people have a family history, they sort of feel resigned to suffer the same fate. And sometimes it can paradoxically cause inaction rather than action. But I tell people that when you have unfortunate events like that, being seen by a physician followed by a cardiologist, being screened and monitored, can significantly lower the risk of that person suffering the same fate, because if there are conditions either present or developing, someone will be on top of it to help, prevent the same outcome. So I would just basically encourage them to be seen by a physician and, not to be resigned to the fact that they're going to have the same fate, because there are things that could be done to change that.
Mm-hmm. Elizabeth, any advice from you?
I mean, it sounds like a really difficult situation. And I think that, what Dr. Bryan said makes perfect sense, that sometimes you do feel, I know it's not nearly the same situation, but for me, seeing, knowing, that in that family line, my great grandfather died in his 40s, then my grandmother, and then my father in their early 70s, it can make you really feel overwhelmed, like, what's the point? I'm going to die also. And it's not the case. I think when you get help, you see the doctor. I know with an enlarged heart, that is a different kind of heart disease, so may have less to do with dietary changes and more to do with seeking medical help and getting exams, so you know what needs to be done. But definitely, like, being proactive and getting the medical help you need can help prevent those things from happening again. So I think, when you're at the moment when, people are able emotionally to listen in a little bit of a calmer way, which isn't always the case right away, but when a little time has passed, it might be possible to have a loving and caring conversation and say, I care about you. And my mother is not in the same line, but after my father passed away, my mother would refuse to go to the doctor. And afterwards, I think after a little time had passed, we were able to talk about it, and she was able to decide to go to the doctor and get medical help and get medication for her cholesterol. Because after some time, when we were a little calmer, we could say, we don't want this to happen to us as well. But sometimes in the first, like right after, it can be a hard time to address those things.
Thank you. Dr. Rios?
Yes, I agree. It's never too early to start a medical screening, particularly if you have the risk factor of having a close family member having a cardiac condition. I think the sooner you get yourself checked out, the better. So I'm very sorry for your loss, and I hope you and your family members can get the appropriate screening.
And we have 2 more questions before we leave. Hopefully we get to answer these questions. Are there any known studies that suggest that higher stress levels impact how cholesterol levels are managed?
Well, typically high stress levels increase a hormone known as cortisol, and this hormone may disrupt your metabolic processes and lead to higher levels of high blood sugar, higher blood pressure. I'm not familiar with any study particularly showing an increase in cholesterol, but definitely there will be an increase in your cardiovascular risk factors with high levels of stress, at least sustained over a certain amount of time.
Dr. Bryan?
No, agreed with Dr. Rios. I'm not aware of a direct impact on cholesterol, but certainly on promoting inflammation and cardiovascular risk. It can increase cytokine levels as well, and along with cortisol levels, as you said, it certainly would increase cardiovascular risk. So I do think there's an association with or a concern regarding excess stress impacting people negatively.
What about added sugar? And the question is, excessive consumption of added sugars raise your triglycerides?
Yes, yeah. So we were talking about that before, especially added sugars, but for some people, even excessive consumption of sugars in fruits and things like that can also raise your triglycerides. So that's why for people with very high triglycerides, they want to have, a moderate consumption of carbohydrates and choose more of the more slowly absorbed carbohydrates that are higher in fiber. So it could be small amounts of fruit, but also whole grains like quinoa or brown rice or whole wheat pasta, 100% whole wheat bread, sweet potatoes, those like winter squash, like butternut squash, those kinds of foods that are higher in fiber are going to be more slowly absorbed and also less likely to raise your triglycerides.
Thank you, Elizabeth. So we are towards the end. We only have like 3 minutes left. So I want to take advantage of these 3 minutes to ask each of you to give a contact information or where patients can make appointments or patients can reach you? Because I'm sure that a lot of people who listen to this will have further questions or would like to make an appointment. Elizabeth?
Sure. To make an appointment with me, you can call the Montefiore Nyack Hospital Community Health and Wellness Department, and the number is 845-348-2004. So we have availability for nutrition consults if you give us a call.
Thank you. Dr. Brian?
So I was typing my information in the chat, but yes, I'm part of Highland Medical Cardiology, and to contact our office, it's 845-268-0880. And yeah, we're available for general cardiology consultations, which sometimes is just an initial visit, but sometimes leads to other testing, whether it's the calcium score testing that was mentioned or stress testing, or but I think the bottom line is seeing someone, whether it's even just a primary physician first and getting evaluated. We're certainly here, my practice, to help anyone who needs it.
Thank you. Dr. Rios?
So I'm currently working at the outpatient clinic in Jacobi Medical Center. So if anyone's in the area and interested on seeing me in clinic, the phone number for our clinic is 718-918-5735.
That
718. Would you like
918
918
5735.
5735. Well, thank
Yeah.
you so much. I've learned a lot. I'm sure a lot of people have too. And, you know, we can't stress enough, cholesterol is more prevalent than we think. And, you know, it's good that you are encouraged after seeing these to know your cholesterol numbers, and you encourage your family members as well. Just to, as Dr. Brian said, it's all about prevention, right? We want to live healthy, happier, longer lives. So, hey, why not? It's just a blood test. So we can totally do this. And next week, we're going to be talking about how we can use mindfulness in order to make dietary changes. So, hey, don't miss that one too, because if you need to make some changes to reduce your cholesterol, we're going to tell you how next week. So thank you so much to our panelists for being here today. You guys are amazing. I always love you for being here and explaining things so easily for our community. And I will see you next week. Thank you so much.
All right, thank you.
Sandra, and thank you, everyone.